Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator, and this is session number 127. Being the first case in the new year, let me begin by first of all wishing you all a very happy new year, and we hope to bring you 12 sessions of absolutely unbiased complex coronary interventions this year. At several corners of the world, it has been the most gratifying feeling having total strangers come up and often tell very nice things about CCC live cases. Those are very encouraging words. I thank the numerous people, and I know Samin, Dr. Sharma often conveys the same feeling. In addition to this nice fuzzy feeling, I also tried to do an honest search, and several of these people come ahead and give us various recommendations which continue to improve our performance, and I hope you will continue the same process. Last week was a visit with the two cardiologists I had never known before in Santiago, Chile, and who conveyed to me that they have been watching for 5 consecutive years our recommendations, and they have made some valuable suggestions which I will share with during the rest of the program. With these words, let me take you to the cath lab where Dr. Kinney and Dr. Sharma are going to show you an OCT guided complex intervention of the LAD. Samin, Anu, good morning.
Yes.
And rotablator, of course, yes.
Of course. Okay.
So Samin, first of all, a very happy new year to you both, and I also noticed something extremely impressive. I have often mentioned this to the viewers. So this is a Tuesday on which, having known you for 35 years, I know you fast on these days. Yes. We do a complex coronary intervention, and both you and Anu have 17 cases each today. Yes. It's going to be quite a day.
Well, that's a usual one.
Usual one, and you are a little under the weather after a long flight coming from India.
I'm so sorry for that, but we'll try to keep up, and hopefully as the case will progress, my voice will come up. But
question I wanted, I didn't reply myself, I wanted to ask. So here is the question, and it is coming from Dr. Iyad Ajamajal. I cannot, Al-Jamal, I'm sorry, I got it now. It is Dr. Al-Jamal. In morbidly obese patients, what type of arterial needle you used to access the common femoral artery? Anything different you do?
Is,
exactly
no,
the same.
Will be micropuncture.
Yeah, first
we'll do micropuncture, and then we will, once you do get the micropuncture, and then we take the picture, we know that you are in the common femoral, then we will go with the larger sheath.
But key, the micropuncture is the key. And that
like here, you see this, how these guys have done it? I can show you playing. This is a micropuncture access.
They can
you can see the bifurcation. And right.
Yeah.
Yes. This is a micropuncture access. If you know you're in the right place, then we'll go ahead, introduce a large sheath. If not, they take the micropuncture out, and then we will hold and go back to the right place. It will take some time, and we know, even the sky is coming up with ultrasound guided access for the vein, for the artery. It takes time to get access, but I think all our fellows have been trained well with micropuncture access for the femoral. Yeah.
Yeah, and I think the important point is how the radial has been touted that has a lower vascular complication, but there is no question in my mind the properly done femoral approach will have a similar vascular complication and bleeding, and that actually was shown in the Safari STEMI trial. So identical vascular bleeding as well as complication in this day and age once you are meticulous with your femoral puncture. So with that note, we actually want to start quickly this case, and we can have the slides, please. The others are not changed. This is the case number 127, and clearly we wish
320.
all our viewers who are more than 10-12,000 per month now, globally, to be our supporter. And of course, every meeting, as you mentioned, you go, they are so thankful what we present. So this case is a new onset, 76-year-old female, new onset class 3 angina with positive stress test, with diffuse ST depression, was only mild ischemia, has only few risk factors, hypertension, hyperlipidemia, and then after the stress test was started on beta blocker. Before that was on amlodipine and losartan. The basically angiogram, which we are going to show now, showed 3 vessel and left main disease.
Normal LV.
Yep.
So this was a right coronary artery who had PCI already. So the stent looks fine.
In the mid portion. Yeah.
And the PDA.
Yeah.
PDA had a stent also. And this is where we are with the left side. So distal left main.
Straight away, the concern is going to be the aneurysm.
Yeah,
Yes.
plus the calcium in the LAD. Now, if you go back here, the main reason the patient had 3 vessel disease and heart team discussion did happen. So if you look at the large OM, there's significant spot lesion, but after that the vessel is moderate size and severe diffuse disease, no place for a bypass. So the surgeons were concerned. Left main here looks, you would say 30-50, but definitely significant disease in the cranial.
Right.
Yeah. No. Now we see it in this view. Yeah.
What also happened is, look at the diagonals, and when we discussed with the surgeon, same, they said small size, they are not going to bypass these diagonals. So then it goes back to that, if we are doing, then it will be essentially right coronary artery and LAD without doing the diagonal will be 2 vessel bypass. Then the patient had a discussion with the cardiologist and felt that should rather have PCI. But here we are going to interrogate the left main with OCT, and if it is significant, of course we'll stent across. If it is non-significant, we'll leave it alone and just take care of the LAD, because there is, if you see the prox LAD, there is a gap. So we can leave the stent after the distal left main just in the proximal LAD about 4 millimeter, 5 millimeter inside.
By angiography, moderate calcification.
Angiography, I would say moderate calcium,
Yeah.
but could be severe if you do imaging.
Straightforward, I heard you, Anu, mention rotational ablation. Would there
Yes.
be a concern taking it through the aneurysmal area?
I think we have shown this case before. As long as
Yes.
you're doing short ablations, should be okay. The concern is the same, that should we have gone then one fiber, right?
Yeah.
And the second
I
question
opened
is
the one fiber.
the 50-60% lesion in the mid to distal LAD, you'll probably leave alone.
I think we'll leave. No, we will stent it, but not do rota in that segment, because the calcium is mostly up to the aneurysm.
And the diagonal?
Diagonal medical therapy.
Okay. All right.
We'll think like surgeons here. But they're not going to bypass, let's not touch it, because of a diagonal D1 could be a moderate size vessel, but if you see that, you'll end up with the full metal jacket of the entire diagonal.
Waited
Look
for
at that.
this day. I know we will learn lessons from the surgeons.
That is
And
correct.
here D2, maybe you can balloon and leave it, but less may be better in this case.
Okay.
So the real query we have at the moment is the
Left main.
Yeah.
So we are going to go with the 7 French only because if left main is significant,
Might need 2 stents there.
2 stents in the circ also. So we go with 7 French, but after imaging we will change our plan. Okay, pull back.
Okay.
Now we'll wait for your lecture, or we go
you
ahead?
You start. So while they are going to interrogate, we'll go through our slide presentations again, please. Yeah. So there basically is 3 vessel heart team discussion. Patient decided no surgery and opted for multi-vessel stage PCI and had a DES to the RCA. And today is for OCT guided complex PCI of the left main and long calcified aneurysmal proximal to mid LAD lesions, whether we use a rotational or orbital atherectomy or plus minus just the high pressure PTCA, will decide based on the OCT finding. So this case, same heart team approach, calculation of STS and syntax score, very low STS, low but morbidity in this particular case, and it will fit into that. Although LMCA may be a bifurcation involvement, but high syntax score
Deep.
with 1, 2, 3 vessel, but CABG was
What size is
declined
that?
by the patient after heart team discussion. So with that note,
Take a deep breath.
it is reasonable that you go ahead and do the PCI. So this is the patient. Clearly, these cases should come out of the table, get a discussion with the surgeon and maybe a cardiologist, and then come back. Yes. I think we may need to take a bigger, smaller guide catheter.
I'll ask a deep breath.
This is the VL 3.5.
Yeah, VL 3.5.
There you go. That,
Little die.
no,
Give little die.
still not.
Yes, see.
You can inject. No, I think we need a VL 3.
Okay.
Right.
Good.
Now, other question is the same for people who think imaging is not there and are worried about the aneurysm. Nothing wrong, I think, even with PTC and stenting across, because that's another option also. Is not heavy calcium. VL3O,
Right.
7 French, yes.
Okay. So we
So,
are going to get with the VL now. 3O guide. Okay, we put back the slide on the main screen while we are getting ready. The 2 points I'm going to talk about is, one is the abbreviated aspirin duration post PCI, because we have the data from the glassy TWILIGHT already and now TWILIGHT ACS, and the new very simple software, imaging software to predict post PCI outcome, that called quantitative flow ratio. And we'll talk about that, what it is. So basically, we know that we have always stopped the P2Y12 in the past to truncate. But what about aspirin? Probably the aspirin is a bigger culprit in what has come in last few years for the bleeding. And that led to the first trial. Remember the global leaders, the trial of ACS versus stable CAD. So what they did is, the patients who are stable CAD, they received, all the patients actually in the trial received aspirin 75 to 100 milligram for 1 month, followed by Ticagrelor for 24 months, twice a day, 90 milligram. In usual strategy is, which we call reference. So that was experimental. The reference strategy in ACS patients was that you give aspirin for 2 years and Ticagrelor for 90 milligram for twice a day for 1 year. And in stable patient,
no die.
Ticagrelor was substituted to Clopidogrel. So basically, it was a study of continuing Ticagrelor for 2 years versus with only aspirin for 1 month, or Ticagrelor 90 twice a day for 1 year for
What do you
ACS,
think?
or Clopidogrel 1 year for stable CAD. And the primary endpoint was all-cause death and
Good.
new QMI. And so basically, this was the trial results, which we had discussed in the past, tended to support experimental treatment group, that is
Ready?
decreasing, abbreviating the dose of a duration of aspirin
Good.
to 3 months. The individual endpoint, and there was no difference in the stent thrombosis or even bleeding. So what happened is, the global leaders was more of a investigator initiated. There was no and reported, there was no quality check in this trial. So that led to the glassy investigator, that is the patients which have adjudicated events within the global leaders, and they looked into either Ticagrelor alone versus dual antifilator therapy after 1 month with the DES. So these are the various endpoints, which I have put it simply into the bar graph. That is, in the experimental group, event occurred in 7.14 with a death MI, a stroke or urgent TVR with a p-value of 0.047. But they made that if it is significant superiority, it should be less than 0.025. So according to the trial criteria, it did not meet. But more important is, look at the individual endpoint, the death, MI, stroke, urgent TVR, and the bleeding. So no difference in bleeding, and also no difference in stent thrombosis at 2-year follow-up. Then the data at the 30 days, same way, the 1 year, and of course 1 to 2 years follow-up. So it seems to be, and it shows that overall, once you have a quality check, overall the trial, if you see some cases, there was a benefit of lower MI after 1 year in the experimental group, as well as definite stent thrombosis, and which is shown here after 1 year. So conclusion of the glassy trial was that the Ticagrelor monotherapy after 1 month DAPT was non-inferior but not superior to conventional treatment in the prevention of ischemic event and it did not decrease major bleeding risk as compared with conventional treatment. Basically because of adjudication of all the events which were done in this particular trial, in the sub-study of the global leaders. So their question comes is, there are a few other randomized trials. We know one of them, the TWILIGHT, which I'll just talk about. There are two other trials ongoing. After acute coronary syndrome, using sirolimus eluting stent, trial called TICO study, giving for 3 months, and then long term of the step 2 depth, which was we showed the trial 1 year in terms of stent use, post stenting, the 3 months versus 1 year, but what happens to them for the long duration is a continuation of the step DAP 2. We'll hear more about. Then in the TWILIGHT, as you can see here, patients were high risk for coronary event, and they were randomized, as I mentioned, that after 3 months, all patients were on aspirin and ticagrelor, and after that they were randomized to ticagrelor alone or aspirin plus ticagrelor, and then continued till additional 12 months, means total 15 months. And this basically was, the trial basically showed that the lower bleeding with this strategy without any compromise in the ischemic endpoint. So this we knew about the study. Now within there, in ACS patients, you see the benefit of the ticagrelor alone was much better compared to stable CAD, which makes about 65% of the patients. So that led to the second arm of the TWILIGHT ACS, presented by our colleague Usman Babar in AHA, and then it's waiting for publication, and the data was similar what was seen in the original TWILIGHT. That is significant reduction in bleeding with a ticagrelor plus placebo compared to dual antiplatelet therapy from 7.6 to 3.6, while there is no difference in the ischemic endpoint of the death, MI, or stroke. And these are the individual endpoints of the bleeding. You can see in all groups, whichever way you want to define, the bleeding was lower with the ticagrelor monotherapy compared to the dual therapy. The question comes why that is, and this was the part of the thrombogenicity sub-study, which they use the body vein chamber and see the platelet PD pharmacodynamic studies, and basically showed that once you use ticagrelor plus aspirin or placebo, basically the thrombus area in both groups were exactly identical. And that is what it basically is. And same thing with the platelet activation. And so, just 1 second before you do, you should do live. 1 second. And okay, so overall, they just want to sum it up, that impact on aspirin duration post PCI is likely that updated PCI guidelines will strongly recommend abbreviating aspirin duration to 3 months, not 1 month, in patient taking ticagrelor for 1 to 2 years post PCI. But what about aspirin duration with prasugrel or with clopidogrel post PCI? We'll talk. Okay, now we can go back to the fluoro, please. We are ready to do OCT right now.
Anu, you changed to a VL 3.0?
Yes.
Okay.
There's a decreased flow.
Okay, flush this.
Show the co-registration and so.
Yeah, co-registration. You can see how he's going to do the co-registration. So essentially distal marker, and you put couple of markers there. You see that? This is a straight line. That's why we'll get a beautiful co-registration. And then once you do that, you will see the OCT. Please wait for co-registration is happening.
What we are looking for.
Okay, so now, no, you'll see that now, if you see that white mark, oh, he's saying 4 quadrants. So if you see the white mark, yeah, go distal. No, I want you to go distal. Okay, you see the white mark, that's where the catheter,
there, right?
yeah. So this is where it is. So now you are at the level of D2, and you're saying it's 4 quadrants calcium right there. Okay, show there. Don't go round. So he's saying the 360-degree arc of calcium. I think you are able to appreciate that. Yes?
Yeah.
Yeah, keep moving. Now bring it forward. Yes.
That's aneurysm.
Oh, there, go back. Shows the aneurysm again. Ectatic, yeah, right there, the level of the aneurysm. Yeah, where is the mouth of the aneurysm? You see it?
Right there. So
That's, oh yeah, that's the thing. Okay, now keep coming forward, proximal, and I want to see the left main now. Keep coming. You can see the white dot coming.
doesn't look too severe there, does it?
That's the left main. Go back.
No, he's not left main yet. They're not in the left main.
You're not in the left main.
Okay.
Why you don't see the dot in the courage?
Read
It become red now?
Yeah.
Oh, okay. Because what is happening is in the areocranial, the circumflex overlaps there, so we are losing it. That's the circ. So stop there and give us a CSA of the left main, distal left main.
4.67. Good. Anything less than 5.5 or even 6.
No, but that's IVUS, not on OCT.
Yeah.
Significant.
The left main is
No,
significant. Yeah.
But no calcium, right? No calcium. Yeah, but calcium is mostly
In the
after
mid-
the aneurysm,
So,
right?
there is a question for both of you. Is there any purpose or role of FFR here?
No, FFR means we know the LAD lesion is significant. There's no reason of FFR there, but you want to do the FFR of the left main, you could do it. But I think once you've done imaging, distal left main, there's no need to do, again, physiological study here.
Yeah.
I think physiological study for indeterminate lesion of the left main, you pick one of the two. If
Yeah.
we decided imaging, we are good. Ostial left main, I would say, maybe FFR probably better, since no matter what, when you're doing ostial left main imaging, your guide has to come out. You definitely cannot do OCT. You have to do IVUS, and often you will not get a good assessment with the IVUS of the ostial left main. But
there
distal
is
left
your-
main, you saw, we got a nice imaging analysis. It's significant. So now for us to decide, do we do a two-stent strategy or just stent across and come out?
Well, to me,
So-
Anu, the answer is going to be that if you are going to be using rotational ablation, would you continue to use it as you proceed through the aneurysm? But
Yes. Yeah, I think we need to do it. We can go
We
back
will
to the
go
angiogram
slowly.
again. Let's play. Go to the angiogram.
Looking at it,
so, Dr. Stewart, that
Yeah.
was your answer regarding the FFR.
Yeah,
Okay.
in this particular case, remember the decision had been made already to revascularize. Patient was supposed to go for surgery, and now with the PCI, I think the FFR role in this particular case will be if you want to leave some moderate lesions alone.
yeah, for
That
moderate.
only will be, but not as a pre. You need to revascularize this patient and then decide. But you're right. Also, in the FAME 3 trial, when they decided CABG versus PCI, the CABG decision was made based on the angiogram, but PCI decision was made based on the FFR. So there is a credence to the system, but the left main was excluded in those cases. And here is the significant left main.
Samin, going back, a quick question regarding the presentation you made on TWILIGHT ACS.
Yeah.
What was the percentage of radial use?
Radial use, actually in the overall trial, the radial use was about between 30 and 40%. Because
So
it was a
should be
global
around the
trial,
same
yeah.
for the ACS?
Yeah, yes. So let's go back to the slides now. The question comes, understood with the Ticagrelor that you can stop the aspirin, but what would you do? If you are taking the Prasugrel, which we know ICER React 5 trial showed Prasugrel to be superior to Ticagrelor in ACS patients, or what about Clopidogrel post PCI? But there is no trial to answer the aspirin abbreviation with any of these two agents. The latest data, which actually some people say the biggest disadvantage of the TWILIGHT or any other global freedom trial basically was that what happens to the patients. What happened to the patient if we would have one arm with a Clopidogrel. So we actually have the latest data from the from the Canada, Vancouver, Canada, about association of Ticagrelor versus Clopidogrel with major adverse event in patients with acute coronary syndrome undergoing PCI. So this is the trial. This basically was the registry of the patients based on their prescription after having undergone PCI for ACS from 2012 to 2016 in Canada. And 7,100 received Clopidogrel, 4,076 received Ticagrelor, and they found whether they were also compliant and there or not, or were switched. But what was the finding? Finding was that Clopidogrel versus Ticagrelor in patients with 1 year PCI, that Clopidogrel group is associated with the overall, you can see the event rate was kind of equal, lower dyspnea in patients with the Clopidogrel, but more importantly, you need to have a matched population. And the matched population basically was propensity match. A score match showed the Clopidogrel, same MACE, same death, same MI, same similar coronary revascularization or stent thrombosis actually was lower with the Clopidogrel, and largely because it was lower bleeding. You see the major bleeding was lower, 4.9 versus 7% with the Clopidogrel versus Ticagrelor. The question then comes, what if you could have stopped the aspirin in both the groups? Then would the impact be different? And so we'll never know that answer. But I'm sure that there should be some more trials will be oncoming to see the stopping the aspirin even with the Ticagrelor as well as with the Prasugrel. Only question remains, because who will sponsor and fund those studies, because both these agents are now non-formulary. So the authors concluded that in this population-based cohort study of patients with ACS who underwent PCI, outpatient use of Ticagrelor was not associated with a statistically significant reduction in MACE versus Clopidogrel. However, it was associated with more major bleeding and dyspnea. So this really contradicts what we have been told until now, that Ticagrelor is very good, but now we actually have many studies looking into this aspect. When you're comparing Ticagrelor with Clopidogrel in this day and age, not the Plato. Plato was a trial done many years ago with a different stents. Now it shows that Clopidogrel may not be bad, and so this basically is our first most important. Now we are ready to go do the rotablation. So let's switch back to the fluoro.
Anu, 175 or 15?
I had opened 175 before, and we are sticking to that.
Yeah.
Nothing wrong in going with 15. Right. And how did I exchange? So since we were not sure the amount of calcium, and because of the aneurysm that we would have, if it was moderate, maybe we would have just done PTCA. I initially went with the run through, and then we took the fine cross, and on the run through I went over with the fine cross. As long as I think
exactly what we've been doing in most other cases.
Yep.
It's 180 run through, so you have to be careful when you are going in with the fine cross. Initially, you'll not have the wire, so you got to do it under fluoro. If the wire is going too deep into some small twig, then stop doing it. Just take out the whole system and rewire with another wire. That's the reason you have to do it under fluoro. And then we changed to rotafloppy wire. Now we have 175 bar, we have a 3020 balloon ready, and we have 150 RPM, and we are going up now.
You said 175?
Yes.
175 bar.
Got it.
Wire.
Yeah.
Pull back.
Yep. You're off fluoro.
No, I am on fluoro.
Earlier, yeah. We can
Pull back. More.
Yeah, once you go there, we'll move it more.
Okay.
Good.
We have to
First the Dynaglide.
pull this anaconda to this side. Okay, we are just doing our 3 steps again.
Do the left main also.
Yeah, we will.
Yeah, just here. Good.
Backward, forward, and just on the dyna. Good.
Good. Nothing. Let's start.
What is happening? Okay. It's becoming noiseless.
No.
Okay. Go fluorosave one little bit. Another way of avoiding radiation is fluorosave. You don't have to do cine for everything.
Right. This is around the aneurysmal segment, just about
Yes.
there.
Yes. See, nice, and I think we did it.
Why it is going down a little bit?
Yeah,
To go
at
up.
the level of the aneurysm.
Good. Good. Now do it. Pressure
No,
is
it
so
has
far
been
good.
going down with this.
Show the
And I'm
hemodynamic-
telling you, SS,
Show the
remember even the other
hemodynamic
day?
tracing on one side.
I don't want to go distal to this.
Yeah.
Don't go too far.
you
It's
can go-
175.
So you can go
I'm
to that
no, no,
aneurysm.
I don't want to go there.
Fluoro, let's see this.
Okay, good. There's no calcium at that level. You want me to
Okay.
go? Okay.
Just do a little polish.
Okay, good.
Good.
See, this is exactly I told you. Many times we see drop in the RPM for no reason.
And do polish.
With
when
this
you're
new burf, I'm done polish.
done. Good. Let's go.
So, Anu, I'm waiting to see the angiogram, and then I have a series of procedure-related questions for you. And the first one is going to be, how do you think would OCT perform here?
Or orbital or OCT?
I mean, OA.
Sorry, OA, yeah,
Yeah.
orbital, I'm sorry.
I
Very
think it will be
interesting,
this-
particularly the response through the aneurysmal area.
Yeah. So,
And the second question also was that what about had you contemplated an impella here? Again, maybe because the EF was okay, you didn't feel it was needed?
Yeah, EF is okay. I think impella would be a overkill
Okay, got
for
it.
this case.
That-
That was my thought
So it's-
too.
Which
But,
diagonal?
yeah, good. Okay.
No,
It's okay. Yeah.
that's
sure.
okay.
Yeah.
As long as they stay like that. Ostium don't have disease. The disease is way further down. I think diagonals will remain like that. OA
so the
probably would have risk of perforation probably higher at the level of that aneurysm with OA.
So the two things which I am noticing here is that the circ is absolutely unchanged and preserved, and the aneurysm looks just okay. So
Now go back to the
hopefully,
OCT and show them the ostium of the circ, which did look free. I mean, of course, you have to do the OCT of the circ itself, but looking at it from the left main, the ostium looked okay. See, only with the tip. Wire it with the tip is twirling in that little aneurysmal segment.
right. This is the run through.
Yes. Now, this
Sameen,
case, you definitely would not do direct wiring with the rotawire.
rotawire, yeah.
You can do it, but it will take a long time.
Well, it'll
So here
continue
we'll take a balloon.
coiling or
Yes.
act very strange in the aneurysm. Sameen, a question for you regarding the thrombogenicity part of the TWILIGHT ACS.
Yeah.
I mean, it doesn't really, I'm not sure if there should be any relationship, but was there any subgroup analysis between patients who may have received bivalirudin, heparin or Ticagrelor to see if the thrombogenicity was affected in any way?
No, that I don't think that's subgroup
Probably
because
not, because,
yeah, there were 50 patients total.
right, right.
Actually 60 originally, and so were like 50 in this.
Good.
The region basically was to see that what is the mechanism of aspirin withdrawal. That by stopping aspirin, do you increase the thrombogenicity in
up here.
our Ticagrelor monotherapy group or platelet reactivity. Answer to that came out that
Okay,
aspirin did nothing.
Down.
That's the key.
Right.
So it was all Ticagrelor. You taking aspirin, not taking aspirin didn't make any difference.
We see some EKG changes. Show the hemodynamics. What did you want?
No, the ostium also, the left main. I mean, distal
No,
left main,
that's
yeah.
what I did not go to the left main. So what's the plan? We are going to stent across or?
Yeah, but you may have
I
to open the circ because of the distal circ disease in the past. Yeah, good.
Okay,
Let's do.
good.
Yeah.
Get me the fielder so I can wire the circ.
This was the 3O balloon.
Yeah, 3O balloon.
Okay.
Okay,
Yeah,
good. Down.
I thought initially you were planning to stent across, but
Yeah. No, that will be the case. Yeah, because you had the
but
distal
that's
left
the
main.
information from the OCT
Yeah.
and how to
Yeah.
benefit from that.
Yeah.
Absolutely. The imaging has to
Take the rope
lead
out.
to more beneficial.
But ideally, if we have to decide circ or no circ ostial, then you have to image the circ also. I don't want to do
Take a
another OCT there.
EKG has resolved in the meantime,
Yeah,
and
just a little bit.
Okay, it
hemodynamics
could
are
be
okay.
from the diag.
Give the nitro.
What did you want? Okay,
Take a
so what
picture.
we will do is we will
the
go.
rotor
You want a
out.
cranial picture?
Yeah. You want to take the rotor wire out now?
Not yet. Okay, we'll take the rotor wire out. Since we are going to go with the wire in the circ, so we'll take the rotor wire out. We probably will need 2 stents in the LED, right? You want to go with the 3O first, and then we put a 3.5 across the left main and post dilate.
To 4.5, sure.
Yeah, 3O38. Patient had a Xience before. Okay, you want to take a picture of the
Sure.
cranial, then we go caudal.
Good.
Wait. Okay, cranial picture, LED. Okay,
Very
looks
good.
good. You want
Looking
3O?
very
I
good.
think 3 to 5.
3 to 5.
3 to 5.
38, yeah.
And then we can put a 3.5.
So the 38, you're going to put it across the aneurysm there.
Yes.
Yes.
Okay. And you're leaving the distal alone, or
No, wow, they are, yes.
Yeah, that one I think
That
we should
will
leave it
be-
alone, yeah.
left alone?
We call psychotherapy.
Good.
Now, I don't want to go into that OM since you're not planning
Leave
to
it.
do any PCI. So we have a 3 to 5, 38, mid to distal LED, and then we'll go with the 3.5 and post dilate the left
That one
main.
with 28.
28 may be too long, 23. Let's see, hold this.
So, Samin,
We are in the wrong view. You want to go
In
there.
the beginning, I had
31,
mentioned
31.
that I had queried the physicians in Chile. So one of the questions I asked them is that how beneficial they thought was our simultaneous translation in Spanish.
Yeah.
And my instinct was that somebody from Santiago, Chile would have said yes. They felt that it was absolutely an overkill and that there is
Some die.
physicians who watch this are extremely conversant
Some die.
English speaking,
I think
and
we are good.
there is
23
really
is
no
good.
need,
Yeah.
Okay,
which is
go.
Yeah.
what we
We
had
saw
kind
that,
of
yeah.
inferred on our own.
Yes.
So I think our proceeding with Spanish was an interesting
12.
experience, but the one to do in Mandarin was a clear overkill.
Yeah.
Down. Go up again. Okay, good.
Somehow the China, in our 138 country, China is like 85th or 86th
Right.
in that ranking. Yeah.
I think we have to sign a phase 1 trade deal with them and get them to be watching more as a part of the phase 1 deal, watch more
Ready.
CCC live cases.
You need to sign a treaty.
Yes, at least that should come up in the phase 2. Watch more CCC live cases.
Yeah.
Good.
Yeah.
So the
So
aneurysm
look at
looks
the.
to, yeah.
Now we can leave it. Post. Post means we may lose the dag. What do you think,
That's
SS?
okay. Well, let's do this first. You do
23
OCT
may be
directly, yeah.
too long, no?
No, 23.
Okay, 3, 5, 23.
23.
That is
Now let's
stenting
go
across
caudal.
the,
Yeah.
that is stenting across the left main.
Yes.
Yes.
We are jailing the wire in the circ.
You probably will need to post dilate the distal
To
left
4.
main, yeah.
4
or even higher.
Definitely. Yeah.
Or even higher, yeah.
What was the left main size there?
4.6 and was the CSA
Yeah.
there.
Yeah. Then you get a photo.
Diameter.
Yeah.
4.3.
4.3. There you go.
Then 4.0 will be okay. 4.0 high pressure will be good. 4.0 12 high pressure or 8?
12 will take us to the LAD with that high pressure.
8.
8.
Yeah, 4.08.
Excellent idea.
You want to go caudal?
So, Samin, there is a, it's not a question, but it's a remark. I'm seeing only the first name, Victor. And the question is that he would have still preferred just a high pressure balloon in
Of
view
what?
of the aneurysm, of the LAD. So
You mean
which
not
is-
put a stent?
No.
Needs,
Rota. Instead of rota.
Rota.
Yeah.
Yeah, that's okay.
Yeah,
Yeah,
we
it's
said
all right.
that in the beginning.
Yeah.
Yes.
Yeah. It's all right. I have conceded that
Yeah.
that's a reasonable approach.
Yes.
No issue at all.
Yes. Take a picture.
But this is the new Philips room where you need magnifying glasses to see anything. Go. Nice. What do you think? I think overlap is good.
That's good. Go.
Are we sure we don't
yeah.
want a
Good.
circ? Leave it alone. Ostium.
Yeah.
Okay, go up. How high?
12.
12.
What stent is
Down.
this?
14.
This is Xience.
3.5, 23.
Go up again. So now 4. This is 23. 3, 5, 23. Going up to 12 atmospheres.
Take inside, do the
Okay,
overlap. Nice.
down. And then what we will do, we'll take a 408 in the left main. We'll go high pressure there, 22.
But take this one inside. The high pressure.
Absolutely
We'll do the overlap.
convinced there will be
Yeah.
some plaque shift into the
Circ.
Circ. Go up here.
Yeah, but,
Go
you've
Enough.
slightly advanced it to extend
Overlap.
into the overlapped. Yeah. Okay.
Yeah, down.
And now the short 8 millimeter balloon to
Ideally, you have to we have to take the wire
Yes.
and recross in the circ before you do the post. You don't want it behind the stent strut. Okay, so we'll take a 408 and then we image.
Yeah, exactly.
Now, did you want to post that LAD
Yes, first.
at the level of the aneurysm?
Yes, you bought this balloon.
We have the
already.
3.0, right? We can go with what size is that?
So let's recross first. Let's do the 4.0 first.
Okay. You want to take a picture or just recross first? I'm going to recross.
Yeah.
actually the ostium looks quite all right.
Yeah.
Didn't
Angiographically, yes. Nice. Now, OCT picture, can you show that again,
Leave it to the proximal
Kishki?
segment only. Go to the one.
So,
at the level of the circumflex.
no, at the level of the left main, at the level of the circumflex, the ostium.
Yeah.
Just
Are you seeing the, yeah, just about there. So the ostium
right
looked good, right?
right.
How many frames? How many frames you got? So now post we will have to see how many frames, okay? We're going with the 4 short 8 millimeter balloon and we'll go up to 22 atmospheres.
And Samin, whenever in the middle you get a chance, let's finish your second topic too.
Yes.
Okay, come here. You can see it. So if you see here, I think we are at the good. Now this one is the only time you may want to do a cine. All the time you've seen me only doing fluorosave. I think one day I want to give a lecture on how to avoid radiation. Keep going. Yes.
I think that is such an important topic.
Go.
And I
Go.
hope
18.
that several
20.
training programs have a
Good.
dedicated short course in understanding
Done.
radiation, how to avoid it.
The proximal edge. Are we fully at the proximal edge? That you
I
can only
think so.
do by the.
I did by the
I
cine.
think it is.
It is.
If
Go to
anything, I
check
thought
it
it
out.
may be a little too proximal, but let's
CSS?
once we.
Looks okay. Good.
Yeah. OCT will tell us down. I think that's it. You don't have to go inside. If you want, you can go inside here a little bit. Yeah. But go like 10, 12. No more. 4. LED was not 4. Okay, good. Down. Now we have mid LED. Are we doing the post at the level of the aneurysm and after that?
I think you can do the same one at low pressure.
No. Do the right thing. It's a 8 millimeter balloon.
So we are 3O.
We have the 3O high pressure balloon, right? Give the 3O high pressure.
Probably need to be a little gentle with that.
Let's take
Okay, we are going to take a left main picture. Ready?
Yeah.
Go. Nice.
Well, something Sir costume as we. So it is the
I think we should go
high pressure inflation which probably did some plaque shift, but
in this particular case, I would say open the circ. No, I would say open the circ for one region because patient has a downstream circumflex disease.
Right.
So if you need to intervene in the future,
you mean in the
we have decided we are not going to intervene medical therapy.
Patient comes back with a MI 6 months later. You have to go.
But look at the disease.
Yeah, but
though.
that time you probably have to go back in. So you can do maybe a 3x3O ostium 8 millimeter. What do you want to do?
I'm not a fan of disrupting left main, but
No, but until flow. You want to give other view? See the flow.
Yeah, I think maybe a little nitro, another view, maybe a little caudal. Yeah, not convinced either way.
Okay, another view.
Okay, let's see here.
Okay.
I think it'll look better.
Ready?
Go.
Very tight. Very tight.
Yeah.
Good. 3 or 12. Yeah, this is separate later. You have to be compliant.
Compliant, yeah.
3 or 12 compliant. Yeah. And then you can do kissing with this.
And aneurysmal area looks just
One more
perfect.
indifferent. Yeah.
What size is that?
This here your 3O.
This is 3O?
Yeah, yeah. Which we had earlier. That's for the LED. This 3O compliant. 312. Okay.
But don't go crazy pressure and you'll for the circ.
Good.
Okay, hold. So this means we'll have to do the kissing balloon. So we're going to go, what size is that? 3O now. We're going to go with the 3O in the LED, 3O in the circ, do the kissing balloon and use the same 3O balloon to the mid LED to post dilate.
Negative. Negative. Negative.
You didn't think the Ostium of the circ needed a larger.
3 will
No,
be okay.
I think 3 or
Pull back a
5.
little bit.
Okay.
Good. I'm going up.
Yeah, 8. Good. Go now to the LED.
10. Go.
Okay, that's a kiss. Again, fluoro save. Down. So circ will come
Pull the
out
LED
and
a little bit.
huh?
Pull the LED back a little bit.
No, I think you're okay. You want to?
Yeah.
No.
Pull the LED back a little bit into the left main balloon. A little more back.
No, you're coming out.
Yeah.
Okay.
Okay. I'm going once again.
Moved a little. Yeah.
Yeah. 10.
Don't go.
Yeah.
Okay, good.
Circ.
I'm taking the circ out,
Yeah.
and then LED we will proceed way further down to the portion.
Cranial.
Yes. So we know exactly where we want to go, and that should be the last step. Okay, I think this is where you want it.
Right. Covering the aneurysm. Maybe a little
Okay,
distal.
go. I'm going a little distal.
Yeah.
Just
Just
not
Let's
going.
go.
We actually have a 3 to 5, right?
No,
What
this
size
is-
you're going?
There's 3.
18,
Yeah. 20.
20. Okay, good.
Pull back a little bit also. Proximal area.
Hmm.
Good.
Down.
Okay. This circ balloon we can remove, and so that we can take a picture.
Okay, we're going to do a final OCT. Ready for the OCT?
Ready?
Okay. Cranial, and then we are going to go caudal. Go. LED looks good. Circ. Let us see. Let us
Like
see
the
what we
distal left
created.
main, how it is. Yeah.
Take the circ wire out or advance.
Yeah, I'm
Black
going to
portion has to be
advance.
out.
Yeah,
Or
I'm
inside
going to
good.
advance only because we are not sure how the circ costume looks.
Okay.
Go. Nice.
Good. Okay. Very good. Take this.
Okay, this picture made us cross the 2O milligrays.
Good. Okay. While they're ready for the OCT, let's go back to our
So we'll do the OCT, and that would be the
slide presentation,
conclusion
yeah.
of the
The
case.
second one is the simple novel imaging post PCI prognostic tool. You say, what is this QFR? That's called quantitative flow ratio. QFR is an angiographically derived FFR measurement
Called the
recently
OMC.
developed as an alternative to invasive physiology. It is derived from the pseudo 3D quantitative angiogram taken in 2 views. No pressure wire for it. And this actually has correlated with FFR. You can see here. So once it gets to the red, means you have a lower QFR. And of course, it started with the normal QFR in the beginning. So it basically is the computer algorithm. So it's basically software. And it has correlated nicely with FFR. So basically, measurement require no pressure wire or hyperemia. And it can be done post PCI setting. And very good correlation with the wire derived FFR. So there are 2 important trials which have been done, which is the favor 2, basically China comparing a QFR and FFR, and basically found a very good correlation of 0.857, as you can see there. And of course the point was somewhere around 0.9. So accuracy really changes at 0.89 was the cutoff. They've understood 0.8 point or more than that in terms of their accuracy, sensitivity, and specificity. And they basically showed that yes, there is a good diagnostic accuracy, but then it went to the second trial, which is Hawk-Eye study. Hawk basically is that very precise in terms of measurement of the QFR after implantation of a stent. They did it for the entire vessel and basically found, as you can see, the MACE associated, which is a vessel-oriented composite endpoint, in the different post-PCI QFR. The cutoff was 0.89. If you're more than 0.89 means 0.9, very good. Less than that, there is an incremental higher MACE rate in this study. And you see here, 3.5 versus 25, almost 8-fold difference in MACE. If your QFR was 0.89 or was above 0.9 and so. So that's really, they went to the cutoff and had a very nice depiction. So what happens is, there is many times there are moderate lesions in the vessel. So if you have lower QFR, probably should optimize them so that later events decreases or within the stent or peri-stent and so. And post-PCI QFR was one of the very important predictor of subsequent event. So authors concluded that lower values of QFR after complete and successful recanalization predict subsequent adverse event compared to, this is the Hawk-Eye study, which basically is that very precise. You know, they say this term, they took it out from the tennis, where the ball was exactly on the court or outside, you know, on the line. And so there are three other available software besides QFR, FFR Angio and V FFR also, but they're getting through the more correlation in the future. So basically, if we had to sum up, abbreviated aspirin duration, post-PCI and predictive value of QFR, the randomized trial involving abbreviating aspirin duration to 1 to 3 months post-PCI on the background of Ticagrelor are encouraging in showing or trend reduced bleeding without compromising efficacy of stent thrombosis. Therefore, in selected patient post-PCI, stopping aspirin after 3 months is suggested, pending updated guideline recommendation. Second, a novel simple computer software of the QFR from two angiographic view has a very good correlation, cutoff being 0.89 for the lower MACE rate, and can be included to optimize your PSI, the results of the PCI, and of course the FFR correlation is still needed.
So Samin, first of all, before you take the questions, I think with the QFR and Hawkeye, we have officially welcomed Roger Federer into CCC live cases.
That is it.
Yeah,
Okay,
right.
we are ready for OCT.
Yeah, okay, let's go for the OCT before we get the questions later. Yeah.
Samin, I have a sense that, you know, they mention QFR as a software. I almost have a feeling that this is more of a predictive modeling they have done and used some artificial intelligence algorithm to create it.
Absolutely.
But
Yes.
will be interesting to see how this develops. Anush, you're showing us the OCT?
Yes.
Okay. So I think the LAD is going to be just fine. The aneurysm should show nice stent expansion, and hopefully the circ ostium will be fine too.
Okay, I'm going in now. We are ready for everything there.
Co-registration of approximately the
we'll
same
see.
segment. Yeah.
Yeah, I'm trying to see that. You see good? Okay, I'm in the guide, right? Come closer. Oh, did you connect?
Call Daisy.
Okay,
Call
Kishki,
Daisy.
I'm going in.
Daisy.
Distal edge.
That should be good
Oh.
enough.
Will not see. Yeah, I'm going to. I think I want left main more than anything else. So forget the distal edge of the LED stand. Okay.
Yeah, but around here the aneurysm is covered, so we should be okay.
Yeah. I want to do one run only. Okay, are we good? Good, not. Okay, can you see? Good, okay. Okay, ready? How are we doing? I'm going to take a last picture.
Wait for your OCT data.
Okay, we are confident. Show the OCT. Oh, okay, okay, yes. Good. So one red line in one spot.
The proximal.
No, that's a distal
portion
edge.
of the proximal portion of the second stent. This area is all fine. This is no problem.
Core edge did not work. Okay, okay, keep coming. We can see it well opposed. Distal edge well opposed. Keep coming forward.
I want to see
No,
the
go
proximal
slow.
edge. Yeah.
Oh, distal edge. Okay.
Proximal edge. Yeah. Right here.
Okay. Well opposed. Okay. Go back to the aneurysm area. Don't fly like a tennis ball, my friend, at the speed of 160 miles. Go, let go slow.
It's not attached.
They got to follow.
There's a gap.
That's the aneurysm there, where you're showing. But first stent is well opposed. Here, the which part? There's some part is not opposed. Why we didn't get core edge? Angle?
That's the diagonal there.
No, yeah, that's so.
septal.
You know, it's under. Yeah, that area. We have to expand more. Huh?
Right. Yeah.
Very bad. Yes.
Is that in the aneurysmal site?
Yeah, yeah, yep.
I
Got a
think
four-
could be the aneurysm site.
440 short.
Same balloon.
8
But left main looks good, right? So show the left main back again, so they can see that how well opposed it is.
Circ origin. Yeah, the left main is okay, I think.
Good. Left main is nice, well opposed. Yeah, that is a key.
And
Okay,
circ
we go
origin?
back. At the level of the circ, give us a number of frames. Oh, now we post dilated, so it does not make any sense. That was our trial, Orbit FFR, where we stented across the bifurcation lesions and we counted the frames pre-post.
It's right there, I think.
Yeah.
And give us the area of that ostium there. Oh, offline, okay. Only the frames you can count. Mm.
Good.
Okay, so LAD is good. Okay, let's go to that part of the LAD. Are we going to go 3-5 then?
4-0.
4 may be too big.
No, 4-0 trial atmosphere is good at that area. Good. So I think we can conclude. I think with this we will just do the dilatation, right?
Just do the dilatation of the segment. Where is the 4-0?
Okay.
408.
So they're going to dilate. Let's go to the 3 questions. The following are the trials of aspirin abbreviation, the duration post PCI except TWILIGHT, global leaders, GLASSY, ICER React 5 and TWILIGHT ACS. As you know, the answer is D. ICER React 5 compared Ticagrelor versus the Prasugrel, but all patients received aspirin. Second, following are the findings of TWILIGHT ACS trial comparing Ticagrelor monotherapy to Ticagrelor plus aspirin dual therapy, except lower bleeding with Ticagrelor monotherapy, similar ischemic endpoints between 2 groups, higher stent thrombosis with Ticagrelor monotherapy, similar platelet reactivity between 2 groups, similar thrombus inhibition between 2 groups. So answer clearly is that your stent thrombosis was not higher with a monotherapy. The last question, the following is the suggested cutoff of QFR associated with higher MACE rates post PCI in the Hawkeye trial, and basically was number 0.91, 89, 92, 95, 96 and 0.89 or below was associated with 8 times higher MACE rate compared to if it was more than 0.9. We can go back to the angiogram now. Yeah.
So this is the 4.0 or 3.5? 4.0, no? 4.0 at 12 atmospheres. Okay. We'll
Don't need to, yeah.
8 here, okay? Okay, good. Okay, down. Okay, ready? Final picture. Go.
Very good.
Nice.
everything looks good.
And total radiation is 2.3 milligrays.
So we conclude
dye?
our today's
160.
webcast now, yeah.
Samin and Anu, thank you for another interesting case. To our viewers, I hope management of aneurysmal dilatations, hopefully we've convinced you that it is safe to perform
Direct 4.5.
ablation across it, and
Looked
plus
okay.
hopefully you've picked up some other teaching lessons. We'll see you next time, February the 18th, for our next session.